Good afternoon. As we know, and as we've heard already several times today, for a number of years, various entities in different parts of the US healthcare system with different roles and in different geographies have evolved their thinking about their responsibilities in achieving greater equity and health equity in our society. The past year in particular, amid the pandemic, as well as due to the killings of Black and Asian Americans, has fueled this evolution even further. We have a distinguished roster of panelists today who will tell us how they and their organizations are going about this very important evolutionary process. Let me introduce them now. First of all, we're happy to welcome Paloma Hernandez, who's President and Chief Executive Officer of Urban Health Plan. That's a federally qualified health center serving predominantly Latinx populations in 3 of New York City's 5 boroughs. She's also Secretary of the National Association of Community Health Centers. We're also very happy to be joined by Sherry Hirota, who is Chief Executive Officer of Asian Health Services. That's a federally qualified health center based in Oakland, California, and serving a population including many Asians and Asian Americans. She's also co-chair of the One Nation Commission, which addresses many equity issues, including COVID and racism. And finally, Wright Lassiter, President and Chief Executive Officer of Henry Ford Health System, based in Detroit, Michigan. Henry Ford, of course, is a large integrated health system with hospitals, health centers, and a health plan with a large Medicaid population. Wright is also the chair-elect of the Board of Trustees of the American Hospital Association. And I said finally, but I didn't mean finally. What I meant is semi-finally, that was right. Finally, we're very happy to welcome Roxy Wells, President of Hoke Hospital in Rayford, North Carolina, which is part of the Cape Fear Valley Health System, based in Fayetteville, North Carolina. She's a family physician by training and is also a member of the Board of Trustees of the American Hospital Association, along with Wright. So Paloma Hernandez, starting with you, Urban Health Plan is a large federally qualified health center, as I said, serving much of New York. And it took on a truly critical role during the pandemic of direct, outside, I should say, of the area of direct healthcare provision. Specifically, you addressed food insecurity and hunger, along with other basic health needs. Tell us about what you did and why, and what was the thinking behind taking on that additional responsibility?
Sure. Thank you for the opportunity this afternoon, and thank you to all my co-presenters on this wonderful panel. So Urban Health Plan, as you said, is a large federally qualified community health center located in New York City. And we have not only focused on providing healthcare services, but also in identifying what are some of the social drivers of health in the community. And this work began, I would have to say, through our years in providing healthcare. We have found that we have really been able to positively impact the outcomes of our patients, not of the entire community, but of our patients. And so when you look at our patients and their good health outcomes, you still see that there is the quality of life, their overall conditions of health have not changed. And so that kind of drove us to start thinking about what else we could do. And one of the biggest drivers of health that we recognized were economics. And so we started to do several things. One, we have a workforce development center that's open to our community in one of the communities that we work. And in there, we provide job readiness, English as a second language, citizenship classes, job placements, case management. And it's actually headed by a workforce expert. And so that has given us an opportunity to impact our community in terms of job opportunities. We also founded a charter school, a local charter school focused on health and sciences, grades 6 through 12, with the idea that one, if we could address health care and we could address academics, that we might be able to impact their future in a very positive way. Plus, we also believe that with the low number of people of color in the health careers, that we could actually create a pipeline within our community to address that shortage. So that's how our work began. We then quickly realized through the healthcare system, our healthcare system, that people were hungry. So we became involved with a food pantry for our elderly in the community. We became involved with developing emergency internal food pantries. So we had a patient who came in, had not had anything to eat, an elderly man, in 3 days. And we just kind of looked at ourselves and how could that possibly be in America? And so we received some legislative money to establish emergency pantries in all of our health centers. So as patients came in, we could actually provide them with food. We also then became involved with food distribution and produce boxes and trying to bring healthier foods into the community. So all of this was going on pre-pandemic. And so when the pandemic hit, it was clear to all of us, it was just a natural that people needed food. And so several funders reached out to me and said, outside of healthcare, what is it that we could do to help your communities? We said, food. That's absolutely food. And so we started out with a small grant. We started out with a few partnerships. And today we have, let me just pull out these numbers because they're pretty amazing. We have distributed 180,000 pounds of produce from April of last year to this year. And it's been in partnership with the city. It's been in partnership with some private corporations who actually identified us as an organization that not only has the reach to distribute the food, but also the ability to quickly act and deliver on what they needed to have delivered. So many of our partners now had goods, food, whether it be food, hot meals, produce, toiletries, but they lack the ability to actually do the distribution. And that's really where we came in. We've distributed over 61,000 hot meals, over 15,000 food boxes, and 25,000 Pampers, female supplies, formula, and the list just goes on. And so what we've been able to do at this time of a lot of need is really serve as a focal point where people not only can come to us for healthcare, for jobs, but also come to us for food. And as a good, deliverable, reliable source, we've been able to provide that. And I think as you prepare to talk about this, you realize the impact that we actually have had and the number of people that have been able to eat because of our efforts. And so I think it's totally in line with our mission of improving health and quality of life. And I think that this is such a clear example of what could be done when you step out of your walls, if you will, of just healthcare and are able to identify need and meet that need in an appropriate manner.
It's really extraordinary. And later on, I'll come back and ask you if 10 or 15 years ago, you even would have thought that a community health center would be engaged in these kinds of activities. But I'll come back and ask you that in a moment. I do want to go to Sherry next. And Sherry, Asian Health Services was more or less at ground zero in terms of the racist attacks that were aimed at Asians and Asian Americans during the pandemic. How did the clinic respond to those attacks, and how will you address that issue of racism against Asians and Asian Americans from here on out?
Thank you, Suzanne. It was almost as if the community went underground in 2020, facing the perfect storm of immigrant bashing, COVID-19, and anti-Asian attacks. We had been organizing around the anti-immigrant policies of the Trump administration for over 3 years, particularly public charge. It had singled out legal immigrants, the majority of whom are Asian, and threatened to deport, punish, or prohibit them from using public services like healthcare, food relief, or housing. What was perhaps more insidious, Suzanne, was that simply the withholding of benefits was on its face the impact of public charge, but it was the narrative that accompanied public charge that was so damaging. Asian immigrants are why Americans are out of work, said Attorney General Jeff Sessions and top White House advisor Steve Bannon. The message was so alarming to us in the Asian community because it was so similar to the message of the man who killed Vincent Chin back in the 80s when there was a fear that the Japanese car companies were taking away American jobs. Spitting and coughing and racist taunting had been occurring too often. And so our community in 2020 began documenting more than 3,000 anti-Asian race crimes, and those were just the tip of the iceberg. But the risk of going underground is also potentially linked to a higher death rate amongst Asian Americans from COVID-19. A UCSF analysis showed that in California, Asian Americans had a case fatality rate of 8.1% compared to the general population, 3.9%. A high mortality rate amongst Asian Americans could mean either that there isn't enough testing or that people are waiting too long to get care. So Asian Health Services conducted a survey of the residents and found that only 3% were getting tested compared to 10% of the rest of our county. And that nearly half could not find a place to get tested, likely due to language barriers. So our community members reported also experiencing physical, verbal discrimination. At the same time, they were isolating themselves. That same survey showed a stunning 73% were not leaving their homes, and many of them were suffering from mental health issues. So this data confirmed what we knew what was happening in our communities. And in fact, Suzanne, this month's Scientific American coverage brings it home with the headline, COVID's outsized impact on Asian Americans is being ignored. And along with Pacific Islanders, they suffer from disproportionately high death rates, hospitalizations, and low testing.
As you have tried to address this, obviously focusing on some of these attacks that have taken place, very, very important. What do you think has been most impactful of the work that you've undertaken so far?
There are many different aspects of working in the context of a pandemic and the onslaught of anti-immigrant sentiment that's been building for years, and also the anti-Asian hate crimes. And so we've been having to work on many levels. On the COVID side, we had to pivot quickly, and overnight, 70% of our clinic services went to telehealth. We are that trusted provider in language. You talked about us having many Asian clients. In fact, 90% of our patients are Asian and limited English proficient, most of whom are living below the poverty line. So as a trusted provider, we're the lifeline to our patients and community who, as I said, were afraid to leave the house. We are currently piloting a trauma unit in mental health for those who have experienced anti-Asian hate and anti-immigrant attacks. We've dispatched mobile testing units and vaccination teams throughout our region to address the glaring language and cultural disparities in our Asian Pacific Islander communities. And while these local solutions have been really, really important, I think we also recognize that we had to network with Asian-led FQHCs and community organizations throughout the country, because that's critical for making impact. We've collaborated with a new initiative and website to document and lift up stories of language barriers to healthcare. So we encourage you to please check out the website asianamvoices.org, and we're documenting across the country problems that Asians have getting access to healthcare because of language barriers. We also continue to be part of the effort to report anti-Asian hate crimes, and that website is stopaapihate.org. And finally, Suzanne, we continue to lift up our common agenda nationally, shifting and framing our own narrative and public policy through the One Nation Commission and One Nation Coalition. So together across the country with our allies, we are aiming to address policy change, legislation, funding, and rules that address disparities and equities. So we invite you to all look at the One Nation Commission report, COVID, and the dual pandemic of COVID-19 and racism.
Great. Thank you so much, Sherry. And thank you for all of this wonderful and so important work. We'll now go to Wright Lassiter. And Wright, of course, the Henry Ford Health System is not a newcomer to the reality of racism and racial injustice. But under your leadership, I think it's fair to say it's undergone a real evolution in its posture to these issues over the past year. Tell us about what you did as the leader of this organization and why.
Thanks, Susan. It's great to be here this afternoon, and certainly it's a pleasure to be with Paloma and Sherry and Roxy as we talk about a really important topic. As you asked the question of what did I do, honestly, the first thing that I did was spend a little bit of time in reflection. In today's world, organizations expect their CEOs to be communicative and to at times bear a bit of your soul around what are you feeling and thinking when issues are happening around your organization. And that's something that I can say that I've not always done as part of my career. But with all the issues that occurred in our country last year, in particular around social injustice and the great pain that our country was experiencing, it caused me to reflect a bit about, frankly, my own story, as a human being, as someone growing up in the Deep South, born in a city called Tuskegee that has history as it relates to treating Black people in a way that's doesn't fully respect their humanity. And so, honestly, the first thing that I did, Susan, was something that I had never done in the same form, and that was I spent a couple really, really late nights when I was not sleeping, writing a letter to our organization. And I wrote a letter to them really reflecting a bit of my upbringing in the Deep South, some of the things that I saw in Alabama growing up, and how it made me feel, particularly as we watched scenarios like George Floyd unfold in front of our very eyes. And, it's not as if the George Floyd incident was rare or unique or a one-off. It just happens that through a confluence of social media and frankly, strength by individuals that we saw more. So first thing that I did was I wrote a letter to the organization. And in that letter, I tried to reflect a couple of things. First and foremost, I tried to reflect the legacy that our organization had around diversity, equity, inclusion. But I also asked our organization if we were doing enough. And I committed in that letter to our 35,000 team members that we would do more. And that, there's a scripture that says, to whom much is given, much is required. And I related a bit of that sort of thinking in this letter to our team members, saying to them that, we exist and we're headquartered in one of the few majority minority cities in the country. And we should be expected to do more. We have resources. We certainly struggle, like many organizations struggle, in serving urban populations and in serving low-income populations and serving people that are vulnerable. But frankly, we have more resources than many organizations. And so we ought to be using those resources probably more than we already have. And I said to our team, let's celebrate all the things that we've done historically, because we had done a lot of things related to diversity, equity, inclusion. We had received a lot of recognition for our commitments and for the things we were doing well. And my sense was we should pat ourselves on the backs briefly and then really look inside ourselves and say, okay, that's nice. So what more should we be doing? And then let's go do it. And so I was really surprised. Maybe I shouldn't have been, but I was surprised by sort of the outpouring of energy that letter generated in our organization. I think in part because anytime you share a bit of your humanity with another human being, there's a greater sense of bonding, and there's a sense of acknowledgement of us as humans. People were inspired to say, you're absolutely right, we should be doing more. And we began to get ideas from around the organization of, well, since you asked or since you committed, well, here are things we can do more of. And so, this is one of those great examples of no good deed goes unpunished, because we began getting lots of information from folks about, okay, so what more are we going to do? And one of the things that we committed to right out of the gate was that while we had always had a lot of activity around diversity, equity, and inclusion, we had never actually developed a organization-wide, system-wide strategic plan focused on this effort, and that we needed to sort of up our game. And this needed to be something that not only was a priority for me and as a CEO and the senior team, it was something that our board would drive and embrace and hold us accountable for. And then I think in particular, because we were seeing such anger and pain in communities of color, explicitly around issues of racial injustice and social injustice, we were very clear that when we developed our new strategic plan, that we would explicitly add social justice to the pillars of our plan. And so while we had focused very heavily on things like our board should reflect the community that we serve, our leadership should reflect the community that we serve, we should evaluate our clinical outcomes based upon, and Sherry will remember this, our discussions in the Bay Area around real data, race, ethnicity, and language data, and segregating our clinical outcomes around those kinds of things. That was fine and good. But we had really never said social justice, advocating for social justice, and frankly, rejecting and eliminating all forms of bias and racism was a corporate tenet that we had ever stated. We probably were philosophically agreeable to that, but we had never said it. We had never said to our team members, we will advocate for and reject all forms of racism. And then I also acknowledged to our team that we shouldn't be naive in believing that bias and racism doesn't exist within the four walls of our organization. And while we can stand up and say that we reject it, and we can't control every environment, but we absolutely can control our own. And so what more should we be doing? We had started a process and a journey around unconscious bias training for our leadership. Our board had gone through that process. Our senior leaders had gone through that process. We accelerated that effort to extend it to lower levels of leadership and to frontline staff. We were very cognizant of the fact that good people don't always produce the best outcomes. And in part, it's because of unconscious bias. In part, it's because of the things that we don't fully understand ourselves. And so we spent a lot of time trying to focus there. We also really began to think through what else should we be doing from a community empowerment perspective. And while we do a lot outside the four walls of our hospital, and we've believed for many years, long before I arrived at Henry Ford, that ensuring the health of a community is oftentimes much more about what happens outside the four walls of a healthcare system than inside our four walls. And we've been focused on everything from, not unlike Paloma's comments around food insecurity. We've been focused on healthy neighborhoods and healthy communities. We've been focused on how do you ensure that communities of color get access to education, childcare, and the kinds of things that make that weave a healthy fabric in the community. So I would say that the four pillars of our diversity, equity, inclusion, and justice strategic plan, which I've been sort of highlighting, more formally, are anti-racism and social justice advocacy, a diverse workforce and an inclusive culture, community empowerment, and then last but certainly not least, healthcare equity. And we'd always spent a lot of time around the things called healthcare equity, but it's really, really clear that in order to make an improvement in both the environment within our organization and the communities that we serve, we had to do more than just focus on healthcare equity. And so those are some of the things that we have begun focusing on, setting ourselves up to have more aggressive metrics around the kinds of outcomes we want to drive in the community. And then saying to ourselves that we can no longer set goals that are solely about what Henry Ford does. We have to set goals that are very explicitly around what Henry Ford does in partnership with others. Because if we're really going to drive issues around improving community health and reducing issues of disparity, inequity, et cetera, that cannot just be done by our efforts, and we have to be aggressive and purposeful in how we partner with others to do that.
Great. Thank you so much, Wright. And as I understand it, I just wanted to draw this out as well, on the notion of the upstream drivers of health in the community and the economic aspects of that, as we've talked about earlier, Henry Ford also made a commitment to a $15 an hour minimum wage as the living wage standard within the organization, correct?
We did, Susan. We had been talking about living wage in our organization before the pandemic began. And, like a lot of organizations, when the pandemic hit and we saw that our financial fortunes were going to be disrupted for a period of time, we began talking about putting it on hold. And then one day we had a conversation and we were talking about community empowerment. And we said, well, one of the most effective forms of empowerment is to ensure that you've taken care of your own backyard. And, in healthcare, Susan, something that we don't talk a lot about is that we have people coming to work every day who live in poverty. We have people coming into our organizations every day, working 2 and 3 jobs, just trying to make ends meet. And we have people coming to work in our healthcare systems, gainfully employed, who are homeless. And so as we began thinking about the devastation that COVID was having on our community broadly, we made the commitment that we have over 3,000 folks in our organization who were not at that living wage standard, and that we should put our money where our mouth was. And our board was very supportive of the fact that we were going to do this in the middle of a pandemic, in the middle of a fiscal year where our economic fortunes were not going to be strong or positive, but it was critically important to take that step, and to say to our team members that we care about your economic well-being. And some of the notes that I've received from some of our team members who talked about not having to work that second job because of the upgrading of their wages, et cetera, has been pretty inspiring. So thanks for asking.
Inspiring as well it should be. Thank you, Wright. So Roxy Wells, to go next to you, Hoke Hospital, which you lead, and indeed much of the Cape Fear system, serves a largely rural population in the Southeast, where, as we know, acknowledgement of racism in healthcare has heretofore not been especially prominent. Tell us what has changed and what must change for your system and for others, both in rural areas of the country and in other parts of the country like the Southeast, and frankly, many others, where racism has been deeply embedded into the culture for centuries.
Thank you, Susan, and thank you to Wright, Sherry, and Paloma for sharing all of the things that they've talked about, that all of those great things that they are doing in their areas of town and their areas of the country. I think that all of those are very important, and they are great examples to what we all can do if we think outside of the box, or if we don't even recognize that there's a box when it comes to taking care of our communities. You know, coming from the southeastern part of America, now having grown up in Fayette, Alabama, which is not far from Tuscaloosa, Alabama, I certainly understand all the things that have been mentioned thus far. Food insecurities, you know, people are dealing with a lot of things across the country, but particularly I think in the South. And I'll talk a little bit about that. Food insecurities for sure, the need and the desire for a living wage. People desire a living wage. Access to affordable quality health care to include mental health and substance use care. Lack of adequate, appropriate, affordable housing, adequate and appropriate being the operative words. Concerns of how best to deal with homelessness for individuals and for families as well. And certainly what we've seen now is the concern for voting rights. And clearly not just in the South, now really across the country. I know that 43 states at least are dealing with voting issues that can definitely affect the rights of Black, brown people, Asian Americans, or what have you. So I've always looked at disparities through the lens of one who has lived them all personally and professionally. The early parts of my career have really been in deep rural areas, and I've since moved to dealing with rural, but also some safety net issues as well. And so when I think about disparities, I think about them in framed as racial and ethnic, of course, gender, socioeconomic, but I also think about geographical disparities that affect people in our country as well. We often forget that when it comes to disparities, location matters. About 60 million Americans live in rural America. And so obviously location matters. And in general, rural communities often suffer the blunt impact of these disparities in a disproportionate way. And that's why you see a lot of rural communities have some of the sicker individuals. Hospitals have a hard time dealing and covering people in rural communities because they just don't have the access to health care that other individuals might have. Um, all of this, of course, is especially true for people of color. You know, there's almost a double whammy, or as I pointed out earlier, there's like a quintet of all of the things that can happen to people in rural communities. Again, food insecurities and all of the things that all of us have mentioned just before. And as I stated, I've spent most of my career either directly or indirectly associated with rural communities and actually grew up again in rural Alabama. I do believe that the brutal history of race relations and racism, particularly in the South, caused individuals in these areas to develop what I call a protective mechanism of repression of the brutality and actual history of racism and how it affects people's health and how it affects people's lives. And so that repression really led to a kind of don't ask, don't tell, so to speak, or let's get along without reigniting what is a painful discussion. And because of this repressive mentality with regards to race in American history, individuals have suffered disparities that should have long been alleviated. The past 4 years from an administration that did not view racism or race relations as important. The deaths of Black and brown people in America at the hands of police, the Asian American violence that is occurring, you know, the issues with what's happening at the border. All of those things have really made us look as a country at what we are really and how we are really reacting to the disparities that people experience. And so the pandemic really illuminated what we already knew existed, what we already knew was present, but we had sort of repressed it because it made us feel better. But now we know the pandemic has shown us that people aren't able to live. Right is correct. People come from home to full-time jobs, and they come from homelessness, and they don't have what they need to feed their families or what have you. So it's safe to say, to me, I believe that health systems across the country, and really all industries, are having to reconcile the stance of health equity and the part that racism has played in keeping us from reaching the equitable state that we seek, or that we should be seeking as a country. But like it or not, racism is a healthcare crisis, and that must be addressed by health systems, and our governments, state and federal, must acknowledge and address it by funding appropriate uh, um, legislative assistance for people across this country. Systems across the country are in various phases of dealing with the crisis. Some are extremely engaged, as Wright has pointed out, and have been for a very long time. Others are awakening. Others are still asleep. And some are just in a complete state of disbelief. And I think that that's where the geography and the location really, truly matters. But until we are all engaged, or until we all become engaged, we will continue to deal with the cost of healthcare in dollars. But most importantly, we'll deal with the cost of healthcare in lives. And as a physician, that concerns me more than anything. And so when you start to look at our state and you start to look at what we've done as a health system, I would say that we are awakening, and really starting to realize and recognize our part in the community, the part that we should play in the community when it comes to making sure that health equity is the order of the day for our health system. And it also, as Wright says, it has to start inside your four walls, because the people that work there actually live in your community. And so how can you talk about something that you're not really doing inside your walls that can go out to the community? So we are an awakening system. We've done a lot of things through the pandemic, things like monoclonal antibody therapy that we've tried to open to everybody, just not certain demographics. We've also tried very hard to educate people on where they could get vaccines. Not only that, we actually did a vaccine clinic, a mass vaccine clinic, in a predominantly African American high school that has a lot of pride, and in the community, and the community recognizes that. And I felt that the best thing to do would be to take a clinic to a place where people recognize, or it has always been a part of the community of color. And so we took it to E.E. Smith High School here in Fayetteville, and over 5 days, we vaccinated 5,000 people, the majority of them being people of color. Asian Americans came. We tried to tear down every single barrier. We worked with the city to make sure that people had transportation via the city buses. We worked with religious organizations to reach out to Asian Americans to make sure that they felt comfortable coming, Latinx churches and groups to make sure that they felt comfortable coming. We had volunteers from across the city who actually stood in line and helped people fill out paperwork. We didn't ask, can you read or write? We just stood there and helped people fill out paperwork to take away that possible embarrassment for not being able to do those simple things. We made sure that we had, people who had mobility issues, people who had disabilities. We did everything possible to make sure that they would be able to get to us to get the vaccine. And so I'm very, very proud of that work. We worked with the school system. The school system here loaned us their school nurses, and we were able to run people through that clinic very easily without any issue. And so I really do think it's a function of, even if you are awakening, it's a function of being open, having an open mind, understanding that you can move outside of what we call the box. And again, I don't like to use that term because, as far as I'm concerned, if this past administration hasn't shown me anything else, it's definitely shown me that there is no box. and I can use that for the good of people who need it most. And so I'll stop there. But those are some of the things that we've done and some of the concerns that I've seen in the South, and just, hoping and believing that we will continue to move forward and not be repressive, but actually work through the things that we need to work through as a region.
Well, thank you, Roxy. Now, all of you have just spoken so powerfully about the role of health systems inside their own walls addressing these issues by getting outside their walls more, moving upstream, coming to grips with those underlying social and economic drivers of health and poor health. In so many different ways, whether it's by addressing, as you said, Paloma, food insecurity and even education in the community through the charter school you established, whether in your case, Sherry, it was documenting some of the racist attacks against Asian Americans and continuing to frame that up as an ongoing and very important issue, the kind of retreat into their homes that the Asian American population undertook during the pandemic that clearly was damaging in terms of social isolation for those individuals. Right, you talked about Henry Ford and the living wage within the organization and raising the wages of 3,000 individuals who obviously are able now to lead different lives as a consequence of having greater economic well-being. And Roxy, you've just talked about getting outside the box and outside the walls, even in terms of the COVID mass vaccination clinic that was run at the local high school. So very consistent themes across all of you about getting outside the walls and outside the conventional box of healthcare. To stay inside the walls for a moment, I just want to talk about leadership within healthcare. And all of you represent leaders in healthcare who have not come up through the conventional healthcare leadership backgrounds that we probably had in place in this country very reliably up until a couple of decades ago. With a very, well, let's call it a very white and very white male establishment within the top leadership ranks of healthcare, with a few striking exceptions. For example, the Roman Catholic sisters obviously stepped up long ago in terms of healthcare leadership. As we think about further diversifying the healthcare leadership workforce, and then more broadly, answering Wright's question, what else can we do to advance health equity? What would be uppermost on all of your lists? And Paloma, once again, we'll start with you.
Sure. When I think about that question, I think in order to make real change, it has to be systemic, and we have to understand that it starts at the leadership level. And so Wright is a prime example of what can be done and what should be done, and how this needs to be part of our ongoing discussions every day. And fundamentally, I think, and people don't often like to talk about it, but how deep rooted racism and social injustice is in our society, and how it drives so much of what happens in our society. And I think that's a fundamental premise that we have to work from moving forward. And so within our organizations, it would be great if every organization like Wright's, like we just did, make social justice and health equity a real tenet of our strategic plans, so that we don't just talk about it and it's not the thing to say today, but that it really lives within the documents, within the structures that really will guide our performance and our behavior. I think that's fundamentally critical in terms of leadership building into the same way that has been done throughout the years, built in racism into our structures, that we reverse that by taking the other position. I also think that we all advocate for different policies at different levels, whether it's state, municipal, or federal, and that before we start just advocating for changes in policy, that we really take the time to understand why those policies were put together in the first place and understand the historical implication that some of those policies had, and what were the underlying premises of them. Because I think that by understanding history, by understanding the foundations of things, is where you could actually really make change. I would also, and this has happened, I know it has happened at the National Association of Community Health Centers, where diversity and inclusion and racial and health equity have become a workforce or a task force. I would go a step further. And how do you really formalize that as a committee that's reported on a regular basis, and again is built into the formal structures of organizations? We can't allow for this to be the flavor of the day, and then it just fade into the woodwork. The pandemic's done, whatever happens, and we just go on. I think it's the right time for us as leaders, for us as people of color, to take a real position in assuring that this continues to move forward, and that it's on top of our agenda, and that we discuss it regularly. Lots of these discussions, I think, are very painful for many of us, because there are experiences, and they're what has formed us as adults, and they are painful, and many people don't want to hear about our experiences, but that's the only way you overcome this, right? So it is painful, but is it necessary? Absolutely necessary, that people understand that this is not a nebulous concept that's not real. It's very real for those of us who've lived those experiences. And so I kind of thought about the whole premise of racial equity, health equity within our four walls and those of healthcare organizations. So if you look at just public health and what guides public health, starting off with awareness and prevention, right? And so how do we bring this to the surface? How do people start becoming aware? How do they start having these conversations in a very non-threatening environment? And then kind of move up to assessing. So how do you really feel about this? How does it really impact your life? How does it impact your practices and the decisions that you make? And I think by getting there, you could actually get to a point where you could actually take action that will really make an improvement in how our organizations work. I think it's our responsibility to continue to promote health equity, to promote racial equity, so that it's up to us to make those changes that are so desperately needed, and will hopefully evolve over time. I don't think many of us will live to see when it's all done with, but I think we all have a work in progress and our roadmaps to put forward and to do the best we can in trying to change things.
Great. Thank you, Paloma. So Sherry, to go to you, what else, to answer Wright's question again, what else can we do? What else must we do? What else must the leadership of healthcare across the country do from here on out to advance equity and address everything that we've been talking about today?
Well, this is a big challenge because we have a lot of history to kind of look at and really understand the root causes of what got us here today. And I was also privileged in this conference to be able to interview Erica Lee, who has a new book out, and it talks about the history of xenophobia. And I've learned a lot through that, and I suggest that we all understand the interconnection between the roots of xenophobia back into the days of the colonies, in which they literally, that meant America and naturalization was based on being white and related to the British. And so from that, people of color were systematically not able to become naturalized, whether you were Black, Native American, Asian immigrants, Latinos, and that those are laws that really have framed the psyche and the culture of America. And so we realize that kind of legacy in the kind of period of xenophobia in the last administration, the kind of hate being manifested from our Asian community's experience or the Black community experience, Latinx community experience, and Native American. So with that, I think that our leadership has to frame a real in-depth understanding of how bias works in our communities and in our health system. And I agree with Wright that we have to get beyond just the solidarity slogans, and we have to get into the kind of bias that impacts our policies in the way that we provide care. And at Asian Health Services, we had created a Black Solidarity Committee of our board and of our staff, and yet the work that needs to happen needs to go back, and we need to take our mental health experts, right? I challenge you to link with us across the country to take some of our best thinking to really understand how does anti-Blackness get understood in the Asian community, and similarly in the Asian community, that we address how anti-Blackness has affected our bias in the way that our communities interact. And I think that we need to start from scratch, because I think that we have relied too much on just, the slogans of, we support each other. And I think that we can do a lot better, and our health system leadership is a good starting point, particularly as mental health is the way a lot of this is sort of manifesting in our community. And lastly, I would like to share a t-shirt that I offered to give to each of our panelists. It is part of that slogan of solidarity. It is Black and Asian unity and solidarity. It was designed by one of the first female Black Panthers in Oakland back in the day, and it has the Black Panther on the front, and in the back, in the Asian languages, it says unity. But my point is we have to keep on the grassroots, because I think our communities have gotten divided, but that at our level in terms of health leadership, we have to take health disparities and health equity and make it real. It can't just be a slogan. It can't be just sort of marginalized. We are tired of being othered, and we will make a difference.
Great. Thank you, Sherry. Wright, the question that you framed to your organization, what else can we do? What else must we do? Addressing that now to the entirety of the U.S. healthcare system and the leaders of health systems across the country. And as we've noted, in your role as chair-elect of the American Hospital Association, how will you frame the additional steps that the healthcare system must undertake to combat racism, to advance health equity, as we've been discussing?
Thanks, Susan. As I listened to Paloma and Sherry, I was thinking that it would be a good time just to cut my microphone and camera off, because they covered so much really deep and wide territory that I was thinking I'm not sure I could add much more to their wisdom, but I won't do that because I know you won't let me. And here's what I would say: a few points. First, I think we need to take an inside out approach. And what I mean by that is, when you talk about healthcare leadership, I would start with this notion that the healthcare industry, from a leadership and from a governance perspective in general, there are obvious exceptions to this, but in general, the healthcare industry does not reflect the communities that it serves. And so one of the first things we can do is put forth earnest effort to make sure that happens. Now, I would say that, to Paloma and Sherry, the FQHC world and the National Community Health Center world does much better at that than the broader hospital and health system world. In part, if they're Section 330 grantees, then they have a requirement of reflecting the community. But even with that not being the case, I think the community health center world does better at that than the hospital world. Our hospital and health system world is still living in decades bygone. And so that's one of the first things I would suggest, because, frankly, leadership matters. And when you have leaders and leadership that reflects the communities that you serve, I think by definition, you have the inclination of having more alignment between the community and the organization. Now, I'm not suggesting by any means that means that others cannot, but I think that's really critically important. So that would sort of start there inside our organization. Second thing that I would suggest to our leaders is that as leaders, and whether you're a leader of color, like the four of us are or not, we can make a personal effort to both mentor and sponsor leaders of color who are coming up behind us, because the reality is that, I think all of us on this call are probably over 39. So that means that maybe we have more work behind us than we might have in front of us. And so one of the things that's a critical responsibility is to make sure that you replicate the things that you hope for, the aspirations of the best of your organization. And so, I would say that it's really critically important. And I use both terms, mentorship and sponsorship, because they're different. And leaders, up and coming leaders of color need both. Sometimes they need a really, really strong mentors to help in their development. And oftentimes they need extremely strong sponsors to ensure that they are discussed in ways that allow them opportunities that they might not get otherwise. And so those are two things that I would suggest inside the four walls of our organization. Outside the four walls, I'd say this, and I had the pleasure of working with Sherry for a number of years when I was in the Bay Area. And Sherry will recall that in March of 2010, there were a few of us who were in a place that not everyone knows about from a healthcare and a healthcare policy perspective, and that is Cuba. We were in Cuba evaluating the healthcare system there at the same time that President Obama was signing the Affordable Care Act. And if I think back to the 11 years that have transpired since then, my view is we have not, as a nation, embrace the fact that the world's wealthiest country still has ridiculous disparities when it comes to access to healthcare. And for a country with all of our resources, there's no reason to have 10, 20, 30, 40, 50 million people without access to appropriate healthcare. And it's really this is not a political conversation about, Medicare for all or anything of that nature. It is specifically around, does our citizenry understand the importance of every member of every community having access to high quality, affordable healthcare that is culturally competent? And that's something that we shouldn't still be debating in 2021. Is that something that makes sense or not for our country? And so that's one thing that I would suggest, that from an advocacy perspective, we've got to figure out a way to get over this hump that this mountain we're still climbing. Paloma mentioned public health, and back to that experience around what we saw in Cuba. Our country also has to understand that we are not going to solve the health inequity issues that exist in so many vulnerable communities purely by the formalized systems of healthcare. Even if all of us, in the way that Paloma described or others described, are doing things that are outside the four walls that are getting upstream, it's not enough. We're going to have to spend both time and resources around public health, and not just about healthcare provision. And that's a really critical point. And then the last thing I would say is that we've got to think very critically about how we finance the healthcare of our country. And we cannot continue to draw a distinction between physical health and mental health. We cannot continue to sort of ostracize those who need mental health services in a way that doesn't allow the fulsome integration of that with what most would consider whole person care. We've got to find a way to finance our healthcare system in a way that doesn't disincentivize upstream activities, doesn't disincentivize longitudinal thinking, that doesn't disincentivize a total cost of care approach of managing someone's health, as opposed to, I'll do these things to you so I can get paid a little more tomorrow. And so those are a few things that I would mention, Susan. Thank you for the opportunity.
Thank you so much, Wright. And before we go last to you, Roxy, and wrap up our wonderful conversation today, just to briefly summarize what we've just heard again, all of the opportunities that exist among leaders in the healthcare system to make a difference going forward. And we've just again heard many of them, doing the kinds of things that Wright, you undertook to become more open as a leader, undertaking mentoring of the generation coming up behind as you continue to foster the growth and well-being of leaders in the health system, leaders of color, understanding the historical roots of so much of our inequity and racism, as you said, Sherry, reaching across silos, forming the kinds of connections that you are forming, Sherry, with Black leaders of federally qualified health centers in the Oakland and broader community to understand your common set of issues around equity. What you've addressed, right, in terms of healthcare coverage and financing, and thinking of that as an underlying source of ongoing, relentless inequity in health and healthcare. And Paloma, all of the very important features that you mentioned that also have to be addressed in terms of continuing to keep this notion that racism must be at the forefront of our efforts to improve. Attacking racism, I mean, of course, must be at the forefront of our efforts to improve health and healthcare in the country. So with all of that, Roxy, you get the last word, a few brief words, if that's okay, to encapsulate all of this and set us off on to the rest of our day of a very important conversation on these issues. So Roxy, your turn.
Thank you. Thank you, Susan. And a thank you to the colleagues, my prestigious, esteemed colleagues who have been on this platform today. You know, I've heard and listened to all of the things that you all have shared, all wisdom, all wise things, all things that we should do in our communities, all of the things that we need to really look at as a nation when it comes to race relations, and tearing down barriers for individuals. You all mentioned things that are extremely important. But the truth of the matter is, and including all of those things, one of the things that we can do as hospital systems in the FQHC world, or what have you, is we have to educate people on the power of their vote. We have to help them understand that every single thing we've talked about today really comes down to the power of that one single vote. And if we can pull people together, if Wright can pull his thousands of people together, if you guys can pull your staff and the people that you serve together and bring them together to actually cast their vote, and not just for people, but for issues that affect them and their daily lives. If we can change the state houses, if we can change the federal Congress, Senate, what have you, then I think that we would have a better chance of actually working through the issues of racism, the systemic racism that we're dealing with. We're seeing it every day right now on Capitol Hill, all of the things that we are appalled at because they stand to take us back to eras that we don't want to be in. And so I would encourage all of us, the four of us and the individuals who are listening today, to empower people to understand the importance of their individual vote. One vote matters. And if we want to change this country, if we want to end racism, it's got to be that we put the right people in the right places so that we can enact laws and Congress and Senate, and even in our state houses, even your local elections matter. And that would be how I would end this conversation, Susan, is that to wrap it all up, if we really want to make positive change in this country, we've got to help people understand the power of their single vote.
And as Mohandas Gandhi said, to be the change that we want to see in the world by taking that change to the ballot box. So Paloma Hernandez, Sherry Hirota, Wright Lassiter, and Roxy Wells, it has been an honor and a privilege to moderate this conversation with all of you today. Thank you so much for your inspiration, your leadership, and your lasting legacy in healthcare in this country. Thank you again.